We hope that you're all enjoying APSA's first virtual annual meeting. On behalf of the Professional Development Committee, we want to welcome you to another of our top educational content, or Tech Talks, sponsored by the Journal of Pediatric Surgery. We hope that you've taken the opportunity to hear from experts address the top 4 educational gaps of our specialty this year. Our only ask from the PDC is that you continue to submit your knowledge or practice gaps via email to think@eapsa.org. Our topic today is one with which many of us have struggled, including myself. I'm truly pleased to introduce a real expert, Dr. Kathleen Van Leeuwen from Phoenix Children's Hospital, to guide us. Her title is Evolution of Care for Patients with Differences of Sex Development. When can we leave the gonads in? Kathy, take it away.
All right, I want to welcome everyone to the virtual APSA Sessions 2020. And I definitely want to give a shout out to Global CAIS for working so hard to get this done. And Dr. Vacanti, the PDC, everyone that's really done as much as they could to make this a meaningful experience. It's definitely meaningful for me to be able to teach you guys about girls with testicles. So we're going to talk about differences of sex development and more specifically, patients with complete androgen insensitivity. They fall under a bigger umbrella of differences of sex development. There are a lot of people interested in kids with DSD, and there's a lot of overlap at the Children's Hospital with colorectal. So I also took the opportunity to do some overlap with the urologists and the pediatric and adolescent gynecologists. So I attend their meetings and get their take on this. There's a very large group of people who work together called the DSD TRN. You probably see one of your logos there. And also the PCPLC has a lot to do with pelvic reconstruction in girls and kids with DSD. That's often what they require. I'm a board member of the Accord Alliance, which is a group that pulls things together for patients with DSD in a neutral place. And I definitely want to acknowledge my mentors that have really pushed me forward in this field and kept me interested. So again, what is a DSD? Well, the umbrella term was formed by a committee of 50 stakeholders from North America and Europe in 2006. And they really were tired of phrases like ambiguous genitalia, although we still use that. Intersex was not popular then, it is now. But in general, we just wanted to narrow this down to definitions that could be studied. And those definitions are chromosomal, they're gonadal, and they're anatomical. And that's a good way, for us as surgeons, that's a good way for us to think about it. So are we talking about 46XX disorders or 46XY disorders in this case? Or is it something where there's a mixture of those, or it's something where the anatomy is just missing or not hooked up in a proper way? So you could refer to all of these things as reproductive anomalies. But if we're going to now narrow that down to just what we wanted to talk about today, which is girls with testicles, then we should talk about XY-DSD. The most common is androgen insensitivity, and the patients we're talking about today have complete androgen insensitivity. So we were taught that the malignancy risk for those patients was high, and that's why we would take their gonads out after they reach puberty. These are those kids that they have primary amenorrhea because they don't have a uterus, but they have a vagina, they have testicles that are intra-abdominal, they look very much like girls, and they don't know they had XY chromosomes until somebody found out in their teenage years when trying to figure out why they didn't get their period. So this is a huge issue for the family. But then when we say we also have to take your testicles out, well, what really is the risk of that? And the answer is the risk is lower than we thought. The people who told us that were the patients themselves. And the risk is probably in the order of 0.8 to 3%. And so if that's the case, how could we let them stay in? And if so, how do we manage that? Well, first things first, let's make sure you have the right diagnosis. There are many other XY DSDs where the risk may be much higher. So if you look at a partial androgen insensitivity or someone with Turner's syndrome with Y material, their risk may be more elevated. So first thing is to make sure you have the right diagnosis. This algorithm is meant to just be a reference, and we're going to print this for you guys to see in a bigger form, but in general, it's just a choice. It comes down to one of two things: take the gonads out or leave them in. But again, you're first making sure you have complete androgen insensitivity. You can confirm that diagnosis usually with a genetic test looking for the androgen receptor abnormality. But I will tell you, there are some kids that do not get that test done for a variety of reasons, for financial reasons, for other reasons. So then it's making a clinical diagnosis, and it may involve doing some imaging or making sure we're talking about the right diagnosis. Then people need to make their own choice by using a decision aid of some sort. We use a checklist in Phoenix that takes them through their diagnosis and all of their options. Then if they choose to preserve their gonads, the benefit there is that they won't have to be on any hormone replacement after removal. And they also feel like themselves. So we would never take the gonads out of a teenage boy or a teenage girl and then just try to replace them. The teenage years, they're making so many hormones that make them feel like who they are, that when you take them out, they actually feel terrible. It's like you're throwing somebody into menopause. So how would you follow them then? The first thing is to get an ultrasound just to make sure you can see them. And then once you locate them, and I was taught that that would be difficult. Turns out it's not difficult at all. But once you locate the testicles intra-abdominally, then you just follow them every year. It's been our recommendation at our institution to get an MRI every 5 years as well, because an MRI is a very reliable study across all hospitals, and an ultrasound is a little bit more user dependent. So we're looking for any changes in the capsule of the testicle or any morphology changes. We don't get tumor markers because tumor markers are too late. Once you have tumor markers, you actually have a malignancy. So it's really more, since these are slow growing things, it's really more radiographic surveillance. What if a patient chooses to take the gonads out? They might not want to be on an annual surveillance in radiology. They may live somewhere where it's not feasible. They may not have the money to do it. They may not have any insurance to get any imaging. Well, the truth is, there are a lot of reasons why people can choose this, but it is their choice. And if they choose to remove them, then they should be removed laparoscopically. That's easy enough to do. And then we should replace their hormones, which is not easy to do. It's not like giving estrogen to someone who you took the testicles out of will necessarily make them feel the same way they did. It may involve testosterone. It may involve lab draws. It may involve a creative reproductive endocrinologist to try to replace those. And we have a variety of connections we use. So this whole topic challenges dogma in a way that we're not used to. So now we're letting patients make a decision about their health care, which again, I think it's important to more and more allow the patient to choose so that they don't have decisional regret later. So in Phoenix, we assess an individual's risk. And we don't just tell them this is what we do for everybody. And we use decision aids to help us do that. And we have them talk to other affected individuals. That's something, the community connection, which is huge. And we let them keep their testicles, to be honest. And they don't call them testicles, by the way. They call them my gonads or my ovaries. But a lot of these girls do not like to call them their testicles because it just isn't something that matches up with how they feel. They feel like girls. This is a picture of my beautiful 17-year-old daughter, who I would never take her ovaries out as much as I might think it would be beneficial. It wouldn't be, obviously, right? It just makes her who she is right now. So you would never do that to one of the other patients. So the big fear I think people have is what happens if they are lost to follow-up? Well, then they take their own responsibility for surveillance, just like the rest of us do when we're doing screening, ultrasounds or screening imaging of any kind. And they need to educate their providers because providers are very confused looking at a girl, often a beautiful girl, and trying to image that girl's testicles. They have trouble saying it in the radiology reports. It's difficult, but it just takes education. And then we can develop teams for them as we have now, but these teams can be a variety of different types. You can have a specialized team of congenitalists. The urologists are a little bit ahead of us on this. They have congenitalist teams for urogenital things. Or for DSD, for this type of diagnosis, pediatric and adolescent gynecology is a perfect team of people to take care of this patient. They'll understand that they don't necessarily need a pap smear every year because they don't have a cervix. So they'll understand things that other doctors forget. This is no different than adult congenital heart or spina bifida. These teams need to be formed if they don't already exist. And I would argue they should be led by pediatric surgeons. So this is a point where in this concept, you can ask yourself, how am I doing with this? Am I left with relief? This is great. I don't take care of these patients anyway, nor do I want to. So now I get to leave their testicles in. Or are you feeling like it's too risky? I don't like the idea. Does this kind of rock your world on the involvement that we have patients make in their other choices? Or do you already do this? If you have a patient with an umbilical hernia, are they making the choice? A patient with pectus, are they making the choice for a repair? As far as the rest of DSD, that is a major can of worms that we can talk about at another time. But more and more, the family and the patient, when the patient is old enough to decide, will be deciding on their reconstructions. And then that makes you think of anything you either are born without or need reconstruction for. At what point do you get to decide? I will tell you that APSA has taught me how to lead this discussion with families and with other organizations using a lot of thoughtfulness, a lot of compassion. We're good at that, so this shouldn't scare anyone. Everyone should say, this is in our wheelhouse, we've got this. I'm happy to answer any questions at all. I have a great team of people in Arizona that do a wonderful job of taking care of this very diverse population of DSD kids. And my national collaborators are amazing. A few of them will be on the call to help discuss this concept. So again, thank you so much to APSA and to the PDC, to Dr. Calkins for working so hard, to Global CAS for working so hard. You guys wouldn't believe the amount of work that goes in behind the scenes. And I'm very appreciative. Thanks very much, guys.